So thank you for asking me to talk. This is, I think, a very important area of cardiology and where we overlap with palliative care. And talking with Karen over many years, our language has finally become, we're speaking the same language, is a huge part of it. So I'm going to start off with perhaps a little run through what is a very fluffy and woolly area. So I come from Offaly, and we happen to we like our sheep. And this is a woolly sheep, and it's what all this kind of thought process, it's hard to get your hands around, it's hard to get any definite grab on what you're doing, and you can get smothered in a whole pile of cotton wool. So lots of cliches. So the only truths are, death and taxes and so on. Now we also have levies, which we'll still have for a long time. So always nice to start with a traipse through the literature, and I always like, if you get George Burns, quite a witty man, if you live to be 100, you've got it made. Very few people die past that age. I thought that was good. Life is pleasant, death is peaceful, it's a transition that's troublesome. Kind of funny, but actually very true. I think that's a very more deep than we think. Johnny Carson said, "For 3 days after death, hair and fingernails continue to grow, but the phone calls taper off." I'm not sure with mobile phones is that true anymore, but and Woody Allen, but I don't want to achieve immortality through my work. I want to achieve immortality through not dying. So there's a kind of a light start, but so I put down this as a new area, but it's not really a new area. We've dealt with this now for over a decade, and there aren't any hard and fast rules. I found the British Heart Foundation document, to which I refer, which is a little outdated now. I found that a good building block, and I know the Heart Foundation here and the hospice movement has moved ahead in a very proactive way. So I was told to keep it short, which I will, and I will also try and illustrate it, because I think illustrative cases make it all very real, and then that might open the way to discussion. So when I think about devices, and by devices I'm talking about cardiac devices, it's device dependent, context dependent, making the decision and then implementing the decision. There's different stages along the way. It is just worthy of mention, while my colleague Dr. Campbell is here, who's a special interest in advanced heart failure, the ventricular assist devices, which we haven't really encountered much of here yet, but it's coming down the tracks, I think, bring their own unique level of difficulty. So I put in devices, that's why I think I have some interest in this, and I also look after patients with heart failure in varying stages, so I kind of see it at both ends. And patients and the people helping to look after the patients, their family, the allied health professionals and so on that now look after our patients in a team-based approach, they have to know what we're doing. The patient has to know first. And I divide therapies, be they pacemakers or statins or anything you care to mention, into that which will make you feel better and that which will make you live longer. There's lots of data out there that patients, and sometimes doctors, and sometimes nurses, and sometimes lots of other people, have this idea that ICDs, defibrillators, will make you feel better. Well, of course we know that's not true. Defibrillators don't make you feel better. They might make you live longer. And so in some ways defibrillators kind of almost are, they're fairly straightforward in that sense, but the patients don't get it. They have this idea that if you're doing an operation on somebody, it's to make them feel better. In fact, you might make them feel worse, because it's been shown that anxiety, although not depression, increases after implantation of device. I suppose the patient comes to terms with their mortality. Cardiac resynchronization therapy and bradypacing are slightly different. In other words, we use this thing called CRT, which is a very useful way of making the heart beat stronger. And that definitely improves mortality now, we know that, but it actually improves morbidity. In fact, we knew that it helped people feel better a long time before we ever realised it actually might make people live longer. So that is a therapeutic benefit in the sense that patients feel better. And I think we'd all agree that, particularly in the palliative care arena, is what it's all about. It's quality of life, maybe not as quantity. So in practical terms, we've made decisions not to replace generators. So if somebody's a device in and they're, say, bradypacing, if they're not pacing very often and they're at an advanced stage of whatever terminal illness that is, it's not unreasonable to not replace a device battery. That's relatively easy, I think. I think most of us no difficulty with that. But the ICDs really do become the issue. And when I started out in my specialist training abroad, we had a lady who was part of a big Italian family, and she had very advanced heart failure, and she had an implantable defibrillator in for several years, and she was actively dying. And that was 12 years ago, 13 years ago. It was very difficult in those days to put the stages in place to deactivate the device. And there was resistance from everywhere, from the patient, from the family, from the ICU nurses, from the doctors, everyone. We didn't really know what we were doing. That's all changed, I think. But it is down to the ICD a lot of the time. And so if you think of ICDs in patients, it's in a patient who has heart failure following the natural history of the condition. So somebody who's had heart failure for X number of years, and they're getting what one of my colleagues calls the dwindles, which I think speaks for itself. There's the ICD patient with cancer, where despite all the best efforts, they're on a terminal progress. And then there's the patient with progressive non-cardiac comorbidities. Dementia, COPD would be the two that spring to mind immediately, and we all encounter these frequently. And then there's the ICD at a great age, for the patients at a great age, coming in for generator change. And that again is a difficult issue, and each patient has to be taken into consideration. And again, I always like these graphs, and you eat, sleep and breathe them, but for me, I think I understand this trajectory with a cancer diagnosis. I kind of understand that if somebody has heart failure and they or their families have chosen not to have an ICD for whatever reason, they are at risk of sudden death, and at a certain time in someone's life that may be an appropriate end. We all agree with that. And then you have somebody with an ICD whereby their course can fluctuate, they can do well, they can get sick, they can be in, they can be out and so on. But unfortunately for many patients the trajectory is generally downwards. And then you get the ICD with degenerative illness. And again, it's where on that curve you say to yourself, would I have put it in the first place? And again, dementia is probably the toughest one, isn't it? It's the most subjective. So I'm just going to run through a couple of cases, and hopefully this is just to generate debate. The first is that of a 60-year-old male who had a history of ischemic cardiomyopathy. He had a remote heart attack. He had severe peripheral vascular disease, and he was not considered a transplant candidate for a variety of reasons that I won't bore you with. He had, in 2003, what was fairly new technology in those days. He got a biventricular pacemaker -ICD inserted. And that certainly improved his lot for quite a while. But by 2007, it wasn't so much his heart failure, which he put down as intractable, but he had pleural effusions that needed to be drained, and he had severe peripheral vascular disease to the extent that he was on opioids. And amputation was discussed, but it wasn't something that it wasn't overt gangrene or anything, so it has basically been managed palliatively. So this was a man that I'd known over a period of many years, and it actually was very helpful for me because in consultation with an excellent GP at Hospice Foundation, we just put him on morphine and we turned off his ICD. We left the biventricular aspect going because it did improve his quality of life, and that really I thought was appropriate, and that was a positive outcome. Another one that was initially presented with mild DCM, and we went out a little bit further because we don't normally put defibrillators in people with mild heart muscle impairment, but she had ventricular tachycardia associated with it, so she had a very solid indication. It's called secondary prevention for her ICD. And we implanted that, and that went okay. And in 2007, lo and behold, she had an abnormal chest X-ray lung cancer. What was upsetting was that all the diagnosis of the cancer was going on at one centre, and all her heart failure management was at another. So you know what happens? So there's no communication. So she came in 2007 into Connolly with symptomatic anemia. And of course, she came in under the general physicians. We don't do medical takes. So now you have a third team, and everyone's trying to get data. So I think a reasonable choice was made not to actively resuscitate, but of course it's Friday evening at 4 o'clock and somebody says, hang on, what's that thing in your shoulder? Oh yeah, So again, luckily because it's a small hospital, and I think actually a certain palliative care consultant in the room had just started around then, I could be wrong, but we actually had good interactions, and we just turned off the thing and there was no problem. But again, it was a bit of a near miss going into a weekend. I mean, anything really, you don't want that to happen. Another case, and this is the one that I haven't resolved yet. It's a very difficult situation. It's a patient born, whatever year, she's 63, 65 now, but she had DCM in 1988, diagnosed in the USA. She would have different ethnicity and different cultural beliefs, but at one stage or other she got an ICD inserted. She developed multiple strokes subsequently and is now in a nursing home with aphasia, hemiplegia, and is wheelchair bound. The issue had arisen that certainly come back to see us, we felt that it was probably, we wouldn't put it in de novo, and the family are flatly and totally refusing to allow us to deactivate it. And the patient herself, I don't think, is capable of communicating clearly. Now, the family will say that she nods her head for yes and nods. It's just very hard to know. And the only way forward really is to actually make her a ward of court, which we haven't done. 80-year-old man. This is just the most recent case, actually. Very supportive family. I put on his ICD when he was 76, primary prevention, very bad ventricle. And in the last few months, he's developed happy dementia. You know, the kind of dementia person that he knows he's a bit, and he doesn't worry, and he's at a great inning, he's happy, he's all very happy. And a friend of his died recently in a nursing home with multiple shocks from device. So they came in to see me recently for their handshake, and he says, oh, I'm grand, my breathing's fine, but listen, will you turn off this thing, I don't want it anymore. So I rang his geriatrician, who's very experienced, and Sean said, well, you know, he's not that bad, like his cognition is is pretty good. Like his MMTS is about 23, 24. But so I said he can make his own decisions then. And Sean said, yeah, but like he's not dying of dementia. And I said, well, he's not dying of his heart. And somebody's turned off his ICD because he said, now he'll make that decision maybe in a year's time because he is on a trajectory of dementia. But his wife consented as well. So that was an easy decision for me. It wasn't so easy for my colleague who's a geriatrician. To me, it makes perfect sense. Because I asked myself the question, if I met him for the first time today, would I put it in? The answer is no, I wouldn't. And he wouldn't want me to. He did back 4 or 5 years ago, but he understands it. He's a very well-educated man. He understood what we were doing, and there was no difficulty. When I put in an ICD with the patients, I always say, look, someday we might turn this off. You have to be open to that idea. So that was an easy one. And then a particularly nice man who lived 80 miles away. In 2008, he was diagnosed as having dilated cardiomyopathy, and he had ventricular tachycardia. We gave him amiodarone to suppress his ventricular arrhythmias, and he got pulmonary fibrosis subsequently. Whether it's related or not, we don't know, but it's out there. And we upgraded him to Bivent in 2011 to improve his quality of life, and he did okay. It was a very difficult case, but we got through him. So I didn't hear from him once a year for the handshake, but I hadn't heard from him in a little while as I was off on the way, and his local hospital is handling a lot of stuff, and he's seeing his pulmonologist who's very experienced and all this kind of stuff. But one day, it was Christmas, last Christmas, I was out in Trentunas in Castleknock, out with my family, and phone rang, and so the GP who happened to know down locally said, listen, this chappie they've sent him home from the local hospital and he's on the morphine drip, and what about his thing? And I said, oh yeah. And I said, grand, does anyone have a mobile phone? And they said, yeah. And I said, well, the first thing you do is, that's a reasonably strong magnet, put it on top, and then give the local hospital a shout. There's a circular donut magnet in every CCU in the country, at least there should be. So ask for one of those and tape it to the top. So we did that, and lo and behold, we had inhibited therapies. Now, of course, what everyone was worried about was you put on the magnet and they're going to die. Well, of course they don't. All the magnet will do in those circumstances is inhibit ventricular therapies. It won't inhibit pacing, so the patient isn't just going to stop. So it's 2 days before Christmas, whatever date it was. The companies used to do it. The companies are fantastic. They have great help at implant, but they don't feel they have the resources to go out and turn out devices in the community. I'm aware in certain institutions people coming into casualty, so taking a poor man into casualty to turn it off in the casualty, it's not a great option. Our cardiac physiologists who are trained to an extremely high level, where do they fit? Are they going to sit into their car at their own liability, drive 80 miles to turn it off? The local centre isn't an implanting centre, and though they have cardiac physiologists, they don't have the technological ability, which is only a laptop computer, but they don't have it and they're not trained, and they shouldn't be expected to do it. So lo and behold, I went down on the Saturday morning and turned it off. Now at that stage he had passed away. And I think the outcome was okay, but I don't think we did all that well. I think we could have done better. And I asked myself, what could we have done? So I think it's probably education. I think maybe if his local centre where he developed the pneumonia on top of the pulmonary fibrosis, it was entirely reasonable to manage him palliatively and it was within his wishes. But maybe a phone call at that stage, say, look, we have this active device, and, but that was I think that was a bad outcome. So, I guess what would you do? It's just hard to know, isn't it? I mean, these are very difficult cases. And devices, like there was a time if you had a device and you're going through the airport, you'd have your own queue. Now there's a queue of people's devices, the way, there's so many of them, So you're all familiar with magnets, aren't you? Yeah, and don't be afraid. In the olden days, the older version of pacemakers, pacemakers used to inhibit pacing for a couple of beats to see what the underlying rhythm was. But you won't do any harm putting a magnet on someone who's palliative, okay? And I had, after a similar case actually in Offaly, I managed to get all the Offaly GPs to carry magnets, which was great for a while, but then they lost them. Okay, so I had to drive. So that's what I thought we did wrong there. I just felt that there was poor communication between the seats. Communication again, isn't it? Like it's all about communication. And, I think again for me as an implanter, it's about getting the patient and the family on board the first day so that when the conversation is had X number of years later that they haven't heard it for the first time. I got a referral the other day from another hospital and it said, please do angiogram and ICD on this patient. And I thought, wow, because an ICD is, I also say it's like puppies aren't just for Christmas, right? An ICD is a long-term commitment, right? And I think somebody before they have an ICD, it's not just the technical issues as regards putting in any acute complications, which are very important and legally we have to explain to the patient, but it's the ramifications and the kick on down the road effect and the fact that someday we might be deactivating this. There was another vogue by some of my very clever friends who said, should we just give them one shock and turn off the other 5? No, it's either on or it's off. I think in fairness, there was a little vogue of that a long time ago. So how to handle it? There's certainly no magic. discussion before implant, I think that's really, really important, and I document that actually now. I'm kind of going to be obsessive about it. I think when you're implanting the first state, the patient has to live 2 years to get prognostic advantage. And I think we're pretty good nowadays at calculating trajectory of disease, including heart failure, by the way. So if you don't think the patient's going to live 2 years, don't put it in the first place. Or if you don't think the patient's going to live 2 years, don't change out the battery. Okay, I think that's very important. And develop a long-term relationship with the patient. This is really important. If the patient's seeing 10 different doctors and 10 different nurses, it's hard to meet someone for the first time and say, hey, we're turning off your box. And I think when a terminal diagnosis is made, I need to get a clear diagnosis from the oncologist a lot of the time. Sometimes they, a bit like cardiologists, they kind of give me the little bit of a runaround. And I say, look, I'm not asking you to read the future. I just want to tell you. And of course, I think with good chemotherapy, what would have been, quote unquote, life limiting is life limiting, but limiting a little bit further on down the road. So it's no longer as black and white as it was. I find the GP is incredibly important to be in the loop. If you don't get the GP in the loop, you'll fail. And 3 minutes, it says. Explain the rationale for turning off the ICDs. The fear people have that if you deactivate the ICD, all of a sudden someone's just going to take a big grunt and it's over. That doesn't happen. And it's entirely in keeping with the DNA order. There's absolutely no inconsistency with it whatsoever. And of course, it's documented clearly in the notes. And like I said, it's our cardiac physiologists, and they have to be borne in mind as well. They're part of our team. They go on a physician's instruction down to a patient, and the patient says, what are you doing to me? And of course, what do they say to the patient? How does it look for them? I'm turning off your defibrillator. Really? See where it goes. So everyone has to understand what they're doing, and everyone has to feel supported, including the physiologist, because particularly some of the junior ones, they may feel that they're harming the patient, but they're not. So when there's dementia, it's more difficult. I think that last case illustrates as well. I think a good argument is, I think if you have dementia and you get shocks, it's not a good thing. You don't understand where they're coming from. Oh yeah, you might say my short-term memory isn't good, but I think the psychological upset is phenomenal, particularly serial shocks. I don't think anyone would wish that on anybody. And again, if the patient is referred for a first implant, will you implant these comorbidities? I think I've covered that pretty well. And then this is the lady that I was referring to earlier. So, but it's another kind of a parallel approach, sort of an ischemic again. She's 84. She's a bit forgetful. She's kind of wondering to have a battery changed. So, what would you do? Any ideas? She's never had a shock. The next battery lasts her 12 years. Mortality from the battery change is incredibly low. Risk of infection between 0.3% and 1%. I don't know. So I don't know what to do. This is the document I found very helpful from the Arrhythmia Alliance and the Heart Rhythm Charity. I think it's a fantastic, document which you can read and download for free. And finally, no hard and fast rules. It's all about relationship with the family. It's a bit touchy-feely, but really the take-home message is, for those of you who mightn't know it, magnet is your friend and phone a friend. I think they're the two things that are the most useful things. All right? That's it.